we'll get started because we've got a lot to get through. And as you will see, this meeting is being recorded, and we've also enabled the AI function. That's just to help with our note taking and key messages at the end. So we won't be sharing anything, particularly private or provocative or anything like that. It's just to help capture any sort of messages that we feel will be useful to share more widely. So welcome everyone to this NHS Highland and Voluntary Health Scotland event. It's lovely to see you all here. I'm Roisin Hurst, and I'm the project manager for the Voluntary Health Scotland's Scottish Community Link Worker Network. And that's a network for those community link workers that are embedded in primary care in Scotland. And we've got a very close working relationship with NHS Highland. Sandra McAllister has been on our network's advisory group since its inception. I was up in Inverness just at the end of September meeting some of the team, and that was a really lovely afternoon just to hear what's been going on. I'm also joined by my colleague Lauren Blair, who is our events and engagement lead. So if you've got any issues trying to hear or access Zoom or any support that you need, just get in touch with Lauren and she'll be able to help. And it's great to have worked with Sandra and Ailey and Jenny on putting together this event this afternoon. I think it's a really exciting time for NHS Highland and the Community Link Worker Programme as you expand your programme. So I think that's a really great time to kind of reflect on your achievements, but also really to think about the next steps and what's coming up in the future. And I think it's a fantastic opportunity for those new GP practices that are joining the Community Link Worker Service to hear from those practices who've already been working with community link workers for a number of years and hear that learning and share that good practice, as well as talk about kind of what you want to achieve next. Certainly sort of with regards to the Community Link Worker Network, the peer support and that sharing of knowledge and good practice is a big part of taking things forward. So I really hope that today is an opportunity for you to connect, collaborate, learn from each other, and just hear about some fantastic achievements from across the Community Link Worker Programme. So I don't think I've got anything else to say for now, but just I hope you engage with this afternoon and that you really enjoy it and get a lot out of it. And thank you so much for giving up your time to come along today. Without further ado, I'm going to hand over to Sandra, who is going to share a presentation from Dr. Tim Allison, Director of Public Health at NHS Highland. So over to you, Sandra, if you don't mind sharing that video. Thank you.
Hello, I'm Tim Allison, Director of Public Health for NHS Highland, and I'm delighted to talk to you about community link working, and I'm delighted that you're here at the event today. I'm sorry that I'm unable to attend live myself, but I am afraid I'm away, and so I've done this recorded message. But for many years, I've had a considerable interest and commitment to community link working, both in Highland and Argyll and Bute, and also in the area that I previously worked. Community link working is a really important way for improving the health of the population, for helping practices with workload, and for tackling health inequalities. Community link working is about breaking down the barriers around helping people to access services, particularly services that are not directly related to health and social care, but those which will help people's care needs and people's health needs. It's around breaking down barriers. We may think about giving people leaflets to direct things, but leaflets don't work in the majority of cases. What people who have the great need is to be helped, to be shown, to be accompanied, and to have someone there who can help them take the opportunities to improve their health and well-being. And that's what community link working can do. Community link working in NHS Highland, in both Highland Health and Social Care Partnership and in Argyll and Bute, has been going since May 2020. Initially, there were 29 practices in Highland and 14 in Argyll and Bute, and because the service is particularly targeted at people with the poorest health and well-being, those practice areas were chosen with the highest number of people who lived in areas of deprivation. And some new practices were added in 2023, and the current number of community link workers in post is 15.5 whole-time equivalents in Highland and 3.6 in Argyll and Bute. The community link worker role is to follow a social prescribing model embedded within GP practices, aiming to address socioeconomic and personal circumstances. And as I was saying, it's around breaking down barriers for individuals to help them access the support that they identified that they need. Community link working service is focused on reducing health inequalities by targeting people who most benefit from things because of, for example, frequent attendance at GP surgery with non-medical unmet need, people who find it difficult to self-refer to support services, those with complex social needs, and those who may face additional challenges when accessing support, those who may need a bit of support to go into a new group environment. Perhaps it could be people who can't navigate services on their own, or those who've got long-term conditions, or particularly those who are isolated. In the first year of the service in Highland, there were 920 referrals and about half that in Argyll and Bute, and that increased in year 2 to over 1,500 in Highland and over 500 in Argyll and Bute. And the reasons for referral tend to be fairly constant, both here and elsewhere. People with mental health and well-being needs, loneliness and isolation, housing and essential needs, financial advice, and stress management. The service was recommissioned in May 2024 in Highland, and the provider changed mental health, secured the new contract for the next 3 years with an option to extend for a further year. Within Argyll and Bute, as I speak, the tender process is underway and will be completed by the time that you hear this, and the new contract is for 2 years from December with the option to extend for another 2 years. I'm delighted that the service is expanding. The primary care improvement money has been able to expand the service within Highland, and we've also got 2 new community link workers in Argyll and Bute funded from Macmillan. So I'm confident that the service is making a difference, will make more of a difference, and I'm delighted that you're here to find out more about community link working and how it can help the population, the people that we all see, and general practices. Thank you very much, and enjoy the day.
Thanks, Sandra. It's a really, really positive and upbeat message from Dr. Tim Allison, and great to hear sort of the story of the evolution of Community Link Worker Programme in Highland and kind of plans for the future. So I'm now going to hand over to Ailey and Sandra, who are going to talk a little bit more about the Community Link Worker Service in Highland and what difference it's made. So over to you, Sandra and Ailey.
Great, thank you, Roisin. I'm just going to do a short introduction. So I manage the Community Link Worker Commission service with the support of Ailey, who you'll hear from shortly, and Cathy Steer, who's the overall lead, is in the meeting today, so some of you will meet her in the breakout rooms. So I'm just going to give you an overview. Hopefully Ailey can move the slide on. We're not used to Zoom in NHS Highland, so I don't know, she might be struggling to do that.
Hopefully that's it now.
Yes, that's it. Well done, thank you. So in year 2 of service delivery, we had 153 referrals, so a 66% increase on year 1. So this could highlight that the service is beginning to embed in the current practices, but it also highlights that we need to manage our capacity, especially with the expansion. There were 2,097 social prescriptions, and examples of these you can read about in the second year report, which will be published shortly. For the first time in year 2, we sought feedback from GP practices, and again, Ailey's going to give you some highlights of our findings from that. We use the short Warwick Edinburgh Mental Wellbeing Scale for those who have completed their engagement with the Community Link Worker Service, and from pre and post engagement, we can see that scores increased by 3.6 points on average, so showing that we're having a positive impact for people at the end of the service. There has been continuity over the 2 years, and in fact across other areas in Highland, because as Roisin says, I link international work, where loneliness and isolation, mental health and financial issues are what are coming through for most services. The focus of the work, as Tim had said, is to tackle health inequalities, and the Scottish Index of Multiple Deprivation helps give a measure for deprivation. Jenny will explain that in her presentation from UHI shortly around how that works in a remote and rural area. But in the practices we have 43.3% of our patients were in SIMD1, meaning that we have reached patients in our most deprived communities. I'm going to hand on to Ailey for the rest of the presentation.
Thanks, Sandra. To have a wee look at age and gender in terms of our demographics, the average age of patients referred to the Community Link Worker Service was 51 years for those who fully engaged, 49 years for those who partially engaged, and 44 for those who didn't engage. Of the 1,535 referrals to the service throughout the year, just over 63% were female, 36.6% were male, and 0.1% were unknown. Referrers to the Community Link Worker Service are able to select one or more reasons for referral, and the top 5 or the most common reasons for referral are listed on the right-hand side of the slide there. The Community Link Worker Service supports everyone on an individual basis, and length of the support is dependent on the needs of the patient, and this can range between 1 and 8 appointments or sessions. On average, each patient engaging with the service had 3.8 sessions with the Community Link Worker. The average was higher for those who fully engaged with the service at 4.1 sessions, compared with those who only partially engaged with the service with 3.5 sessions per patient. The second year report also includes a number of case studies that hopefully show the impact that the Community Link Worker Service has had on individuals that have been referred. Meet Alex. Alex was referred to the Community Link Worker by the GP due to being socially isolated following their family's relocation to the Highlands. Despite the move being positive for the family overall, Alex was struggling to make new contacts and missed their family and friends. The Community Link Worker and Alex spoke in depth about several issues that Alex was experiencing, and together explored potential options that were available to address these. The Community Link Worker is able to discuss these issues at length and can provide a lot of knowledge about some of the resources, activities and services available in Alex's local area that could provide help and support for some of the issues that they have identified. In partnership, the Community Link Worker and Alex developed a plan with a focus on decider skills, addressing their bereavement, volunteering, developing confidence, increasing social interaction, as well as looking at some longer-term mental health support. Regular check-ins between Alex and the Community Link Worker took place to review progress, goals, outcomes, and any challenges or barriers that arose. Alex said that they had felt the benefit of talking out loud about their grief and loss, and in doing so, they came to the realisation that they had not been able to move on and therefore would benefit from some bereavement counselling. Alex attended Decider Skills and said that they had found the sessions beneficial. It was helping them to recognise their emotions and reduce anxiety. They felt more optimistic about moving forwards. Following the sessions, Alex felt that they were able to be kinder towards themselves. Alex found that they were beginning to look forward again with hope rather than feeling sad. And at the 8th and final session with Alex, Alex was working through their grief following a recent and close bereavement. Despite this, they were able to now, have the tools available to help cope and to understand that grief was a normal reaction and knew to seek help if their feelings persisted. Alex's SWMWeb score had increased from 15.84 at the time of the initial appointment to 20.73 at the final appointment with a community link worker. And Alex had advised that they had benefited greatly from their sessions with a community link worker. In April 2024, a survey was sent to 29 GP practices that currently benefit from the community link worker service. The aim of the survey was to better understand how the community link worker service had been operating over the last 2 years, provide insight into what prompts GPs to make referrals into the service, and understand the impact that the service has had on the practice. 20 survey responses were returned. We asked, do you want to continue to access the community link worker service? And out of the 20 survey responses returned, all of them said yes. We asked practices how the community link worker service had been received in the practice, and some of the responses received are on the current slide, but I'll give you a minute to read these quotes. But generally the themes were that it was well received, it was an asset to the clinical team, it was worthwhile for patients, a refreshing change, and that the community had engaged well. We also asked practices what has gone well with the community link worker service, and again some of the responses received are on the slide. And again, I'll give you a second to read these, but the themes were that it was a positive experience, positive support, time and consistency given to patients, there was help taken away, or the service had helped to take away from the GP's heavy workload. It was helping patients to access services that were perhaps unknown to the practice, and that it was collaborative. We also asked if there was any areas in which the community link worker service could be improved, and we'll be covering this in our discussions in the breakout rooms a bit later on. And finally, in relation to the survey, we asked practices, do you think that having the community link worker service has helped save practice staff time? And of those that responded, the majority, which was 76%, said that the community link worker service had helped save practice staff time. Guidance was created to support GP practices that are making referrals into the community link worker service. It provides information to support GP practices to introduce and embed a community link worker into their multidisciplinary teams as part of the ongoing community link worker service delivery. It also provides information about how to refer into the service and how best to utilise the community link worker resource. The guidance has been shared with all Highland GP practices and is available on TAM, which is the Treatments and Medicine portal. And finally, looking forward, the service expansion is underway to ensure that a continued focus on health inequalities, distribution of the additional resource has been rolled out using a GP cluster-based model, so organising link workers into clusters with each cluster serving as a focal point for coordinating services and support. The development of the directory of services has been running for just over a year, and the project has been extended until summer 2025. In addition to it being developed for community link workers, the directory will be available to anyone in Highland and will be available to access through the Highland Third Sector Interface website. We will keep you updated and let you know when the directory goes live. And to support the wider social prescribing approaches, a multi-agency coordinating group has been established. And if you'd like to find out a bit more information on this, please let us know. Our second year report will be available really soon, which we will be able to share with you. Thanks very much for listening, and there'll be an opportunity shortly to take any questions that you may have.
Thanks, Ailey and Sandra. That's really great to hear kind of the difference that the Community Link Worker programme has made. And, you know, the endorsement that you got from the GP practices on kind of the community link workers and the impact that it's had on them is really, really good to hear. So thank you very much for that. We're going to go to Jenny Dryden next, who is going to talk a little bit about the Community Link Worker programme across Argyll and Bute. So challenges, progress and next steps. So over to you, Jenny.
Thank you so much. Thanks, Sandra and Ailey, for the introduction as well around community link working. Now, I am new to Zoom. We normally use Teams, so can I just check you can see the presentation? And it, you can see it's moving okay, but it's not. It looks like it is now. Okay. Right, okay, so if you can all see it okay, that's fantastic. So we're off to a good start. Thank you so much, everyone. Thanks for being here today. I'm really delighted to be able to talk about the community link working service across Argyll and Bute. So my name is Jenny Dryden. I'm one of the health improvement leads in Argyll and Bute Health and Social Care Partnership. We also sit as part of the wider NHS Highland Directorate and Public Health Directorate, sorry. And like Sandra and Ailey, I support the Health Board, or in my case, the Health and Social Care Partnership side of the service. So supporting the contract tender process and implementation, helping the service provider to engage with GP practices and really making sure everything's in place so that the community link workers can go in and do their job supporting people. I'm really pleased to be here today to give you a flavour of what community link working looks like across Argyll and Bute. Similar to Highland, Argyll and Bute has had a community link working service since 2020, 2021 and has been available in to patients in 14 of the 29 GP practices across our remote and rural area. So today I will tell you about what our service looks like, some of the challenges that we've encountered since introducing the service, what success we've had and what difference the community link workers have made, and also share what next for the service over the next few years. And hopefully that has moved on, so just give me a shout if it's not at all. So just to give you an overview of community link working and what the model looks like in Argyll and Bute. So the Scottish Government doesn't specify a particular employment model for community link workers. Some are contracted to third sector organisations and some health boards are direct employers. Within Argyll and Bute for the past 3 years, the Health and Social Care Partnership has contracted the third sector provider We Are With You to deliver the service for the region. And I'm really delighted that there's some people from We Are With You here on the call today. So we currently have 3.6 full-time equivalent community link workers operating. It's 12 GP practices now. It was 14 at the start. That doesn't mean they've reduced. It's just because some of the GPs have merged. So there's been no reduction in GP practice, but we now, the official number is now 12. And like in Highland, the selection for these practices was strategic. So it was based on what Sandra mentioned is the Scottish Index of Multiple Deprivation. So that focus is really on targeting provision at the areas of highest deprivation and that to the people who need it the most. And this targeted approach aligns with that overarching goal of reducing health inequalities and catering to those who are facing the most complex socio-economic challenges in our communities. Currently, the service covers 78% of patients in the lower half of the most deprived areas of Argyll and Bute, and we are going to be expanding that when the new service is in place from December 2024. And I really wanted to include this photo here of the very small but perfectly formed community link working team in Argyll and Bute. This photo was taken during one of their team meetings up a hill in the countryside, which is a great place to have a team meeting. But the reason I want to share it as well is because when I'm talking about the successes and differences that the service has made to communities in Argyll and Bute, what I'm really talking about is the difference these individuals have made. It's really easy to think of a service as an entity, as this abstract being, but actually these are the link workers that are on the ground providing support and improving lives. And I hope you'll see that when we come to share the quotes from the people that they have helped. So it's putting a brand new service in place is not without challenges. So I thought I would touch on them briefly today, because it's good to be aware of these, especially if you're here today and you're getting a community link worker in your practice for the first time. One of the first challenges we encountered when we were first putting the service in place was around raising awareness of the service and building relationships with busy GP practices. So the pressures that primary care are under will come as no surprise to people here today. And there's sometimes aspects of adding in a new service that can feel like more work rather than reducing that workload, which is one of the aims of the service. For example, GPs and other practice staff have to take the time to learn about the service, meet the link workers, welcome them into the practice, understand the referral system and pathways and what the appropriate referrals look like for the service. The community link workers as well also have to raise awareness of link working, build those good working relationships with practice staff and with the wider community. And it can sometimes be challenging for link workers to feel integrated with that wider multidisciplinary primary care team when they're sometimes working out with the practice and they're not employed by the practice or the HSCP. Fortunately, our GP practices in Argyll and Bute have really embraced the community link working approach, and our service provider, We Are With You, is experienced in making these connections in primary care, so we've ultimately been able to overcome these challenges. Having resources within the community to support people can be another challenge. Community is, after all, key in the title of community link working. And if community support isn't available, then it reduces the ability of link workers to help. However, our community link workers are able to fill gaps. They can identify these gaps. They can fill them with group work or through partnership, or they can feed these back strategically through various methods within the health and social care partnership, so that we can try to address them in other ways. Finally, two challenges that are more difficult to overcome, but I'm sure you'll all be familiar with: rural travel, so particularly around the ferries, making it difficult to reach Highland practices, and getting room and space in practices which are very, very busy. Again, fortunately, our link workers have been able to mitigate these challenges the best they can by using community venues and telephone near-me support when appropriate. So on to progress for Argyll and Bute. This slide highlights the top reasons for referral into the service, which stayed fairly consistent, and they're also consistent with Highland and the top reasons for referral that Sandra and Ellie have mentioned: mental health and well-being, followed by loneliness, financial advice, stress management. And down the bottom just shows the sort of varied mix of things that the community link workers can support with, and some of the other referral reasons as well. The service has an 84% appointment engagement rate, which is excellent and really shows that there's a very low percentage of do not attends, which is great. We also have the number of referrals coming into the service increasing each quarter, which is fantastic. It shows increased awareness of the service and also increased acceptance from GP practices that it's a good service to refer into and that it will make a difference to their patients, and it really highlights the need for the practice, for the service. In terms of outcomes, Argyll and Bute also use the short Warwick Edinburgh mental wellbeing scale, which I'm very pleased that I managed to say as well, Sandra. And again, that's administered at the start, the initial session, and then when the patient or the client is due to complete their time with the community link workers. We have information from around 58% of people who have travelled through the service, and 90% of those who have completed this outcome measure have experienced a positive change in their health and well-being, and an average score of increase of 5 points on the scale, which is fantastic. It really shows that people are engaging with the service, and actually that it is making a difference to health and well-being. In terms of client feedback as well, we have a huge number of quotes from clients who have been through the service, and I just thought I would provide some of these here today. People told us that definitely feel that having the link worker support me and help me find the correct resources has made a huge difference and achieved so much. I'm very grateful for the time, effort and compassion that was shown to me, and I feel like a lot of people would really benefit from the same experience I had. I felt pills on their own were not the answer to my problems. It has certainly helped me through a very dark time in my life. The links worker was my lifeline, and my favourite quote, I have Dr. X to thank for the best referral any doctor has given me. The community link worker allowed me to talk, get upset and be non-judgmental. I'd never have thought 4 months ago I would have improved so much. So some really powerful quotes there, and that they're fairly consistent throughout the service. We have a high percentage of people feeling it was easy to get an appointment with the link worker, feeling listened to, treated with respect and compassion, and who would recommend the link worker to other people. Oh, too fast. We also, like Highland, gather feedback from the GP practices as well, and collaboration with the GPs is a really crucial part of the service, of how effective and integrated it is, and how it can make a difference for patients. And also for the community link workers as well, who report that primary care teams make them feel really welcomed and supported. Some of the quotes that we have from GP practices are that the link worker has an excellent knowledge of services available to patients dealing with social problems, taking work off GPs and other practice staff. Thanks for sharing the evaluation. We just want to say how much we value the service. Community link worker is worth her weight in gold. We have had positive feedback from patients who have really needed her support, and know that we need to keep your service in the minds of the GPs. We don't want to lose this service. I value this service greatly as part of our multidisciplinary team, and it's always a pleasure to have the community link worker here on site. GPs did recognise that there were some challenges with embedding the service, because it was strange having a member of staff present who wasn't employed with the practice and was developing those working relationships, but this has largely been overcome. Oh, one. Sorry, I've missed out a slide. You still see that okay? Yes, hopefully. Yeah, can see now, great. So final slide, sorry, apologies about that. Next steps in our Highland Buttes. So we are expanding the service in December 2024 to cover additional remote and rural practices, and that is the additional funding that Tim mentioned at the start, that we've been grateful to receive from Macmillan for 2 full-time equivalent community link workers. And also over summer last year, 2024, we undertook engagement with GP practices to identify where those workers would sit and what the next cohort would look like. So we've gathered feedback from rural practices about how valuable and how much of a priority this service would be for their practicing area. And that's when we are planning to implement the additional remote and rural community link workers with a self-referral option likely to be available as well. And I can finish this time. I can press next steps. Thank you.
Sorry, I was on mute. Can you hear me? Yeah, Brill. Thanks very much, Jenny. It was really good to hear kind of what's been happening in Argyll and Bute and hear the progress that you've made as well. So thank you very much for that. So our final presentation before Q&A is going to be a recorded presentation from Jenny Hall from the University of Highlands and Islands. And as I'm sure a lot of you are aware, the University of Highlands and Islands has been doing an evaluation of the Community Link Worker Service. So Jenny's presentation is going to talk about what they've been doing to date and what we can learn from that. So I'm going to hand over to Sandra, who's going to play that for us. Thanks, Sandra.
Hello, everyone. I'm Jenny Hall. I'm a rural health researcher at UHI. I'm sorry I can't be with you today, but I've recorded a short presentation to share some of the work we've been doing on evaluation of the Community Link Worker Service in Highland. Our analysis is still ongoing, so what I'll give today is an overview of some of the findings so far. Social prescribing and similar approaches have been practiced in the NHS in areas of the UK for many years. Some schemes date back to the 1990s and some even earlier. For example, the Bromley by Bow Centre was established in 1984. However, there still isn't much evidence on how or why social prescribing impacts health and well-being, particularly in a remote and rural context. We aimed to use robust methods of data gathering so that we could present data in a way that matters to policymakers and service commissioners, in addition to providing feedback to those involved with delivering and benefiting from the service. The underlying assumptions for introduction of a primary care-focused social prescribing service are that there are social determinants of health which can be addressed through non-medical interventions, that people with non-medical needs can be identified within primary care and primary care staff will refer patients to link workers, that link workers have the skills and information to support patients and successfully prescribe, and key to all of this is that there are community-based activities available to refer patients to. The selection of practices for overall inclusion in the initial phase of the Community Link Worker service was based on the percentage of registered patients living in the most deprived 2 deciles in the Highland Health and Social Care Partnership. Practices with greater than 10% combined SIND 1 and 2 were included. Our evaluation focused on remote and rural, so we set an additional practice urban-rural classification criteria of 3 or greater. We began the evaluation with 8 practices, shown in red, and later added an additional 7 practices in green at the end of March 2023. Our focus was patients living in urban-rural classification 3 or higher. To begin with, we needed to understand how the service was working in practice and how to identify patients to invite to take part in the evaluation. So, in overview, the service is delivered for NHS Highland by Change Mental Health. The key components are the community link workers employed by Change Mental Health and attached to specific practices, primary care, and organisations offering community-based activities. The patient journey through the service begins with a GP appointment, where a non-medical need is identified and the patient agrees to a referral to the Community Link Worker service. The referral is made by the GP via Elemental software. The Community Link Worker picks up the referral in Elemental and then contacts the patient or client, as they are then referred to talk with the client about what the Community Link Worker service can offer. At this point, some clients decide they no longer need the service, or when they find out more about it, they decide it's not for them, or in some cases, clients can't be contacted. All of these clients are then closed within Elemental. For clients who want to continue with the referral, a meeting is arranged, either in person or by phone. Sometimes all a client wants to do is talk, often more than once, and not want to get involved with any community activities. These clients complete their pathway through the service without any specific onward social prescription. Other clients will have a single meeting and go away with a list of possible onward prescription or referrals to community activities, while other clients may have several meetings with their community link worker and also participate in community activities. So the journey through the service is very individual. One of the criticisms of previous evaluations of social prescribing was lack of control groups. In an attempt to address this, our original evaluation plan was to focus on 3 different groups based on their engagement with the service. Group 1 was those who engaged and went through the service. Group 2 included those who were referred but then did not engage. Group 3 was those who had a non-medical reason but were not referred to the service. In practice, we had significant problems with lack of engagement with Group 2 and challenges in identifying people in Group 3. It became clear why the inclusion of a control group has been challenging in evaluations. Because of these challenges, our patient data collection is based solely on Group 1, those who engaged with the service. Having established the patient group we were working with, quantitative data collection began. Community link workers were tasked with handing out questionnaires to those engaging with the service at baseline, as close to the start of their interaction as possible, and then posting out follow-up questions after 3 months. Questionnaires were designed to collect demographic data and also included WEMWebs, EQ5D, the Lubin Social Network Scale, and a number of free text questions asking about patient expectations of the service. These final questions were to inform the development of more structured social return on investment questions for the follow-up questionnaire. The follow-up question was also designed to gather data on services and activities that patients were referred to and what they attended or engaged with, as well as the structured questions for SROI analysis. In practice, only a handful of baseline questionnaires were returned. It was at this point that the additional practices were added to try to increase numbers. Discussions with community link workers highlighted some potential reasons for the low number of returns. The community link workers felt that it wasn't appropriate to give the questionnaire to everyone. There was concern that bringing up the subject of completing questionnaires might impact their relationship with clients so soon after meeting them. There was also feedback that the questionnaires were too long and didn't feel relevant to their clients. Perhaps the EQ5D was too medical for people with non-medical needs. EQ5D had been included partly due to its acceptance in economic analysis. We decided to pause data collection and reconsider our approach. We identified an alternative tool also acceptable for economic analysis, but much less widely used. This is a tool called the IceCap-A, which is a capability measure with 5 domains covering stability, attachment, autonomy, achievement, and enjoyment. Each domain has 4 statements to select from which are related to feelings on ability to achieve within each domain. Community link workers felt that this would resonate more with clients, so we developed a reflective endpoint questionnaire which included 2 sets of IceCap questions, one to be completed based on how the client felt now after they had completed the community link worker program, and one reflecting back on how they felt before they met with their link worker. With the journey through the pathway so personalised, this makes more sense than sending out fixed time point follow-up questionnaires, as the length of time that clients engage with the service varied depending on their needs. The new questionnaire also included a structured SROI question based on those baseline questionnaires which had been returned, as well as being informed by the literature. Free text questions were also included to provide an opportunity for clients to share what their expectation had been and whether and how the service had impacted them. Our work in health economics and social return on investment analysis is ongoing and will be reported on in the final evaluation report early next year. But let's look at the characteristics of the patients being referred to community link workers from the rural practices. In terms of age, 31 to 50 and 51 to 65 year age bands each make up about 30% of total referrals. 18% of referrals were 18 to 30-year-olds, 14% were 66 to 80, and 6% were aged 80 or over. There were a small number of under 18s referred. However, these will have been rejected as inappropriate because the service is for 18 and overs only. 65% of referrals were female. Moving on to look at SIMD. Looking at the left-hand chart, 50% of referrals were from SIMD 1 and 2, the target of the initial phase of the service. However, 31% were from SIMDs 3 to 5 and 19% from SIMDs above 5. If we look at urban-rural classification, the breakdown on the right-hand side, 63% of referrals were people living in small towns, with the remainder from other remote and rural areas. If we look at referrals by both SIMD and urban-rural classification, we can see that the spread of SIMD across each classification perhaps highlights that deprivation as defined by SIMD is not the only driver of non-medical need referrals across remote and rural areas. Looking at general outcomes for those who completed their journey through the service, 57% were recorded as having their needs met, 26% were referred on, and 88% were listed as being in meaningful activity. The evaluation team collected qualitative data through interviewing, shadowing, and focus groups. Patient interviews relied on direct contact from patients with the evaluation team using a paper or online contact form included with questionnaires. The patient interviews did not begin until the endpoint questionnaires were introduced. 7 patients were interviewed, 10 community link workers were interviewed, and 9 community link workers took part in 2 focus groups. 3 GPs, 1 practice manager, and 5 people from 4 third sector organisations were also interviewed. The third sector organisations were identified by looking at the frequency of referrals using data that was captured within Elemental. Analysis of qualitative data is ongoing, but emerging themes include layers of complexity of patients referred to community link workers, understanding of the community link worker role, which came through with all interviewee groups. There's an overarching theme of communication between all parts of the service. And from a third sector point of view, overall capacity and sustainability in rural areas is a challenge. A key message from those patients who engage with the service is that it provides a space to talk and be listened to. To summarise, all the evaluation data has now been collected, analysis is ongoing, and findings will be presented in the evaluation report early next year. Some findings which have emerged so far include the observation that referral for non-medical needs in rural settings may not be as clearly linked to SIMD as in urban settings. Patients valued a space to talk and feel heard. And from an evaluation point of view, evaluation of social prescribing is challenging, perhaps even more so in a rural setting. We've had many changes in the evaluation team since we began, but the original evaluation funding application to CSO was driven by Professor Sarah Ann Minoz, Sarah Bradley and Anna Terrier, with support from Kathy Steer and Sandra McAllister. Rebecca McLean has carried out the majority of the qualitative work. Professor Nicola Carey is now the PI on the project. Thanks to Rosita Novak and the team at Change Mental Health for ongoing involvement, advice and support. Many thanks for listening.
Thanks, Sandra, for sharing that. And yeah, it's really good to hear sort of where the evaluation is currently at. And I'll be really interested to see I think she said that the kind of economic return on investment is going to be out next year. So I think that'll be really interesting to see as well, because I think that's something that is often talked about. And I totally agree with her that it's really difficult to evaluate social prescribing. And I think some of the kind of challenges that she highlighted around kind of complexity of patients and also understanding of the community link worker role, I think are things that are reflected kind of nationally. So we've finished, well, we've reached sort of the end of the first half with the presentation. So we have around 10 minutes now for questions. So if anybody's got any questions that they would like to ask of Ailey, Sandra, or Jenny, if you want to raise your hand, we can try and ensure that your questions get answered. So is there anything anyone would like to ask? I might kick us off then, because I had a question, and I think it was around the presentation on the Highland service that Sandra, you and Ailey did at the beginning, and just sort of the differences, I guess, between the numbers of males and female patients engaging with the service, because I think it was 2/3 female and 1/3 male. So it was just really to ask, what you feel that the challenges have been around engaging more men in the service, and what you might do to try and ensure that they're aware of the service and feel comfortable engaging with it, or whether you just feel that there's more need for women to engage in the service more generally.
Somebody from a GP practice can maybe back me up on this, but I think more females attend GP practices than males, because males don't seek out the same level of help as females, but I could be wrong about that.
Okay. There's actually a GP practice has asked a question. So Andrew, he says he's a GP in Granton-on-Spey and asking when is the service coming to them?
Soon, we hope. We are hopefully having Elemental integrated now or over the next couple of weeks. And Rosita can maybe, or Sharon can maybe come in and tell us if they've got staff covering Granton. As soon as these two things are in place and the GP practice is actually met with change, then the service is ready to be running.
Right, so not long to wait. I don't know if anyone else wants to come in and say anything more about that or not. No. Okay. So any other questions for Ailey or Sandra or Jenny on the progress to date? Andrew's posted another question in the chat. Do referrals have to go through GPs, or is there any other way that patients can access the service? And I guess that might come back as well to the question that I asked about, with regards to obviously more females accessing their GP practice than not. So yeah, if there are people out there that you think could benefit from the services, there are other ways that they can access it.
No, the referrals, as this is part of the primary care modernisation, and the funding to support that comes through that, it's entirely for GP practices. So if you have a look at the guidance, Andrew, you can see that anybody within your practice who has got access to Elemental, once that has been set up, can refer. So I think that we have referrals through people that are the community mental health team, some of the first contact physios. There can be referrals through anybody in the practice that sees patients, that has a conversation, that recognises there are social issues that somebody could be supported with.
Thanks, Sandra. And Mary from, I think it's Eastdale Medical Practice. We are in Argyll and Bute. Is it likely we will get a community link worker, and when?
I don't know who to put my hand up with Roisin, but I'll just come in if that's okay. Yes, Eastdale Practice, you are on the list for the next lot of service, which will be, well, the contract starts in December, so recruitment for the new additional link workers will start shortly after that. We do have some communication that's coming out to all of the new GP practices in the next couple of weeks that will give you some more information on the next steps. But yes, it will be very soon.
Brilliant, thanks, Jenny. So there's obviously lots of interest in when the community link worker service is going to reach those practices that really need and want it. So that's fabulous. Andrew again wants an explanation on what Elemental is.
Okay, so Elemental is a social prescribing platform that integrates with Vision. And so when you have an Elemental account set up for you, you can start inputting the patient detail information for from Vision for that patient will help to populate the referral, and then you send it, and that is then picked up by the community link worker. We were very mindful at the very beginning from the focus work we did with our steering group that ease of referral was something that GP said was a must for the service. So this hopefully is as easy a way of referring as it can be. There are a few boxes that might require additional information if there's things about a patient that a community link worker would need to know. But that should be being installed in your practice over the next wee while, and there is guidance in the guidance that Ailey talked about how to use Elemental, but it should be straightforward and easy for those referring through it.
Thanks, Sandra. And he's just asked a follow-up question asking if this is different from the Green Health Link Worker system that they had.
Yes, it is. And we've been in touch, and Rosita and her team have linked in with the Green Health Link workers. So Green Health were there to prescribe for, I guess, green health activities. Community link worker will not have a predefined reason for speaking to an individual. The referral will come through for the reason the GP or whoever is referring has identified, but it's very person-centred. So whatever the patient is looking for support with will be what guides the community link worker.
Andrew, you're bossing this Q&A session. I have to hand it to you. Another question, are link workers generally based in the practices?
Ideally, that is the best outcome for everybody. They become integrated in the team, and awareness, and there can be informal chats. It depends if you've got space, Andrew.
Brilliant. And Andrew, you don't need to apologise for the questions. These are all really great questions. So thank you very much for all of them. Sharon, I wasn't sure if you were trying to say something, or I just saw something in the chat. I don't know. It might have been your cat. Right, okay. Does your cat have any questions? No. That's fine. Okay, I think this is probably where we can have a wee comfort break. So we're about 5 minutes behind time, Sandra. Is that okay? Do you want to allow people to have 10 minutes to go and get a cup of tea and we comfort break? I think we allowed 10 minutes in the program. So
do people need 10 minutes? I guess what's the consensus is slightly less than 10 minutes, 6 minutes or something. We like this when we're doing training. Enough time for people just to go away and get a cup of tea or coffee.
Yeah.
If we can try and come back in about 6 minutes time, just so we've got room. We've got less people in the breakout on the call, so the breakout rooms might be more manageable as well. So I'm okay if people are not back for a wee bit longer than 6, but if we could.
Okay, that's fine. Well, go and get yourselves a cup of tea or coffee, go to the loo, stretch your legs, and we'll see you back at just before 22. Thank you. Welcome back, everybody. Just getting everyone back into the main room. Welcome back. Hope you had some good discussions in your breakouts. So Sandra, I was just going to go around each breakout and just get a couple of points from each. That'd be okay. So I think in room 1, that was Jenny's group. Jenny, I don't know, I presume you were the facilitator. So, but if you or someone else from your group would like to feed back a couple of points, that would be great.
Yes, no problem. Do you want me to feed back a couple of points about each question, or just in general?
I think just in general, and I'm sure we can write up the notes. We can share the notes from the breakouts, and we can write that up.
Yes, I'll write up the notes from it as well. So in our breakout room, we spoke around about how to decide who would refer into the service, and spoke about those patients who were struggling to engage with groups, or who didn't know about what support was available in the community, or who wasn't motivated to attend. We spoke about the guidance pack that Highland have developed, and using that to look at the examples of referrals in order to determine what was a sort of an appropriate referral into the service. We also spoke about the challenge, because the practices within our breakout room don't have the service yet. So we didn't talk about what might need to be improved, but instead we spoke about what some of the potential challenges might be and how we would get around them. So an interesting point was that the busier practices get, perhaps the less likely they are to refer because they are so busy. So we spoke about some potential mitigations in getting around that, reminding, having some sort of reminder system for staff, making sure there's good relationships put in place with the link workers, and raising awareness of the service with patients as well through various means.
Brilliant, thank you. I think the practitioner the practitioner guidance pack's a really good idea, and yeah, I think there's quite a lot of interest in something like that across the network. Room 2 was that Ailey's group. So Ailey, I don't know if you or someone else would like to feed back just a couple of points from your discussions.
Sure. So we touched upon all discussion points, but for the first one, just really about referring patients with non-medical social needs, and also again about, and it was picked up in the UHI presentation as well, is about that understanding of the community link worker role for both the referrers into the service, and kind of for the community link workers as well, to kind of set that expectations when they're speaking to the patients at the kind of initial appointment. I think we skipped to kind of discussion point 3, looking at the future, and we thought we could maybe do a bit more about the gender differences. Didn't come up with an answer, but we maybe needed to look a wee bit into that, and if there's something more that we can do to kind of help with more males being able to access the community link worker service. Continue to promote and evidence the impact of the community link worker service. And also we talked about what happens next. We can sometimes evidence folks' kind of short period through the community link worker, but we're always curious as to what happens maybe in the wee bit of the longer term, for example, 3 or 6 months or a year down the line. So we spoke about that. And then for discussion 2 about the benefits, really kind of easing the load for GPs and freeing up clinicians' time for more time with consultations with patients with medical needs.
Brilliant, thanks, Ailey. That's really useful feedback, and it sounds like you had a really good discussion. Room 3, I think that was your room, Sandra.
It was, and we spoke about sometimes having only a 15-minute appointment for a GP can make it difficult to pick up when a referral might be relevant, that the medical need will be the focus. And if they come in with a long list of needs, then you know, that opportunistic conversation might not happen. So discussions around, you know, who else might be best placed to refer. On a very positive note, the service was seen to be very responsive, have a very good pick-up rate, and patients were supported quicker and not left in limbo. And a few suggestions about improvements for the future, maybe stuff around self-referral, moving towards prevention, and then we had a wee bit of a discussion about elemental at the end, but I'll share that for my one wee rant at some other point.
Okay, thanks, Sandra. And then finally, room 4, I think that was Kathy's group. So I don't know if it's you, Kathy, or someone else that wants to feedback from that group.
Yeah, no, I'll feedback. It was only myself and June, so we had a nice chat. I think there was some technical issues and maybe some folks who couldn't join our group. So, but we had a good chat, and June's practice is about to get a community link worker. So we didn't quite stick to the script. But what we did talk about was in terms of how decisions are made about who to refer. We talked about the importance of having a discussion around that as a practice, and you know, particularly for practices who don't have a community link worker yet, about considering that. One of the things that we highlighted was that it might not always be, for example, a GP or a practice nurse who might identify who might best benefit from the community link worker service, but reception staff, particularly in smaller practices, know patients very well, and they are in a good position to identify who might benefit and to be able to flag that for referral within the practice. We talked a bit about the benefits of the community link worker service, and certainly that notion that, you know, that within the patient cohort that there are some obvious candidates who could benefit from the practice, but because it wasn't a practice that hasn't got a community link worker yet, it was difficult to identify the benefits for the practice themselves. And we talked as well about the importance of just making sure that the community link worker is embedded and part of, as much a part of the practice as possible, whether that's about, you know, inviting them to multidisciplinary team meetings, inviting them to social events, bringing them into the practice, or giving them space in the practice whenever possible. And finally, I think we recognise that with it being a new service, and I guess a new way of working for a lot of practice staff, that there would be a need to keep reminding staff about the community link worker service and what it's there for, so that they get into the habit of thinking about that service when they're looking at the more holistic needs of patients who come through the door.
Brilliant, thanks, Kathy. It sounds like, even though there were only 2 of you, you had a really good, rich conversation there. So thank you for that. And I think it sounds like that, yeah, there's a lot of shared learning gone on already. And I think for those new practices that are coming on board, you know, I'm really excited for you to have a community link worker and the benefits that hopefully that's going to bring to your practice and patients. But I hope that this is the start of you being able to, you know, share learning across the community link worker program more generally. You know, it's today is, I guess, the start of doing that, but as those new practices get their community link workers, I'm hoping that learning can continue, because they'll be learning that they're getting, and the existing practices being able to support them. I think it's really nice to have that kind of peer-to-peer support. So we will ensure that we capture some of the key messages from today, and Sandra, we can liaise with you about how best to do that and gather up all the information. I don't know, Sandra, if you wanted to say a kind of final word to everyone before we log off.
I offered Kathy the option, but she's put me in the hot seat, so that's absolutely fine. Well, I just want to say a huge thank you to everybody for coming along. We hoped that putting it online rather than face-to-face might make it more accessible. We've had people who requested for it to be recorded, and that's hence the reason that we've done that. And it's been a great opportunity to kind of learn from practices about, you know, what's happening for them, because now that there's going to be 62, us getting to talk to each practice is somewhat of a challenge. I guess thank you to Tim for the recorded presentation, and to Jenny Hall and my colleagues Jenny and Ailey for their presentations too, and to Voluntary Health Scotland for hosting this on our behalf. I hope that we can use the learning, we'll share that with you, and that the service continue to grow in both Highland and Argyll and Bute. And thank you to the staff that deliver a fantastic service to patients. I think that's hugely recognised by everybody.
Thanks, Sandra. Yeah, I think we all know how brilliant the community link workers are. I'm always in awe of the work that they do. And I think this is a great opportunity with the expansion of the programme in Highland to really be able to spread the word about community link working and the benefit of social prescribing and what that can do for people in rural communities. So the best of luck as the service goes forward, and keep learning from each other and keep talking to each other. And if there's anything that we can do at Voluntary Health Scotland to help support that through our work, then we're more than happy to do that. So thank you very much, everyone, for coming along. I hope you keep warm. I hope there's not too much more snow in the next couple of days, and have a lovely weekend when it comes. Take care. Bye-bye.
Thanks, everyone.
Thank you.